Hello, this is Rebecca with another lecture for MedSurg 2 on nursing care with patients with endocrine disorders, Chapter 39. So if you haven't watched the previous lecture on just the assessment with endocrine, I'd really recommend to go ahead and do that. I'm going to go ahead and share my screen now so you can follow along with the PowerPoint. Presenting. I'm presenting. Okay. So our objectives today are outcomes. We're going to talk about the various disorders caused by hormones of the pituitary, thyroid, parathyroid, and adrenal. These can be pretty confusing because some of their symptoms can be very similar. But we are going to go through, we're going to talk about the pathophysiology, their signs and symptoms, and hopefully get a better understanding of them all. We're also going to talk about therapeutic measures. So how do we help these people with these diseases? Talk about our assessment or data collection with these patients, planning what is their nursing care that we're going to do, and then how do we evaluate whether if our care has been effective? Some of our core concepts are cellular regulation, fluid and electrolyte, growth and development, and nutrition. So I want to step back for a minute. We talked about the assessment of the endocrine system in the chapter 38 lecture that I recorded, but I just want to kind of remind you of a couple things. So when you're looking at endocrine disorders, it's all about our hormones in our body, and we're either producing too much or too little for the most part. Occasionally, there's some tissue sensitivity that's involved. And when we're producing too much or too little, I just want to remind you guys that for the most part, our endocrine system, it's run on a negative feedback loop. When I say negative feedback loop, it's kind of what I talked about last lecture when I talked about insulin and how our body, we eat something like the candy, something sugary in general, that sugar and enters our system and our bloodstream, and we stimulate that feedback loop, which is a negative feedback loop, because then we say, okay, I need to regulate that amount of sugar that's in my system. So then our body produces insulin from the pancreas, which then allows the glucose to be absorbed by the cells or stored in the liver. And then when that glucose level drops, then that insulin production drops as well. Negative feedback systems are what kind of keep our body in regulation. Mostly, there's also positive feedback systems. Those are mostly what you're going to talk about, or when I think about positive feedback feedback loops, excuse me, I think about things like labor and birth. When a woman goes into labor, that is a positive feedback loop where instead of trying to regulate and bring something into balance, it's actually circling more and greater until the accumulation is delivery of the baby. And so that's a kind of example of positive feedback loop versus negative feedback loop, which is usually most of our hormone production, especially in the diseases that we're talking about today. Um, when we're also talking about these diseases, the different endocrine glands that we're talking about, it's either a primary disorder or a secondary disorder. And what I mean by that, it's either primary, there's actual dysfunction in that system, or it's secondary, where something else is causing something, causing an issue. Like if we're not getting enough thyroid stimulating hormone to the thyroid, well, the thyroid's going to be in dysfunction because it's not producing enough um, thyroid hormone. um, but it's not an actual problem inside the thyroid. It's another gland that's not stimulating that release of the hormone, or the thyroid stimulating hormone. So just so you know, it can be either primary, the actual gland is having an issue, or secondary, it's something else that can be causing that. Okay, moving through. So let's start talking about antidiuretic hormone. So you can either have too much or too little. So too little, remember we talked about antidiuretic hormone in the previous lecture. So let's break it down. Antidiuretic. So diuretic is when you're diuresing, you're releasing water, you're usually urinating, you're getting rid of that fluid. Well, anti means it's against. So we're actually retaining fluid, we're retaining water when we have antidiuretic hormone. So if we have too little of that, we're actually going to have a lot more urine, right? Our body isn't keeping the fluid like we need it to. And so you'll have often you'll see a disease like diabetes insipidus. Too much antidiuretic hormone means that we are keeping too much fluid in and we are overloading ourselves with too much fluid. So let's talk about diabetes insipidus first. I want to just baseline set diabetes insipidus is completely different than diabetes mellitus. They're two vastly different diseases with the first word being the same. It gets kind of confusing for people. There are times when it's some of the symptoms can be similar, which I wonder if that's kind of where it came from. But just know diabetes insipidus, nothing, not the same at all as diabetes mellitus. We're going to talk about diabetes mellitus into week 4 and 5. So diabetes insipidus, you don't have enough antidiuretic hormone. So your kidneys aren't reabsorbing water, which means you are going to be releasing, or these patients are going to be releasing all this water. They're going to be diuresing or urinating 3 to 5 liters a day. That is so much. So why would they have this issue? So pituitary hormone, right? The ADH antidiuretic is produced by the pituitary. So if you have a tumor or something that's causing dysfunction of the pituitary gland, it can cause, where you're not producing enough antidiuretic hormone. It could also be something with head trauma or surgery that's altered the pituitary gland. Certain drugs can stimulate this as well. So signs and symptoms, they're going to be peeing all the time. Their body is just letting go of all the fluid. Because of that, so that's polyuria, that's urinating very frequently. Because of that, there's going to be polydipsia. Oh, let's go back up. Polydipsia is increased thirst. They're extra thirsty because they have been peeing so much, they are dehydrating themselves and their body is saying, no, you need to get more water in because I don't have enough. Nocturia, they're peeing at night. Their urine is going to be very diluted. So it's going to have a very low specific gravity. They're going to be dehydrated. They might even enter into hypovolemic shock with decreased level consciousness and eventually death if it's not treated. So what are the diagnostic tests? Like I said, the urine's going to be so diluted, it's going to have a very low specific gravity. That's for the urine. The urine is very diluted because we're just getting rid of all the excess fluid. But the plasma osmolality is going to be increased. Plasma osmolality, that's our blood, right? We are getting rid of so much extra fluid that our blood, with all the red blood cells, the white blood cells, plasma, the platelets, everything is becoming more concentrated because we don't have as much fluid. So it's kind of a converse reaction where your urine specific gravity, your urine is very dilute while your blood is very concentrated. So they're probably going to do a CT scan, maybe an MRI, to see if they can find the cause, see if there's something usually with that pituitary gland. They might even do what's called a water deprivation test. And it's very uncomfortable for these patients because they are urinating so much that they drink water constantly. And so and then you do this in a controlled setting in a doctor's office or a hospital. And when you don't let them drink any water, and what happens is they are like dying. They want to drink so much. But what you do is then you keep measuring their urine and you're checking the specific gravity. Because you and I, normally, if we don't drink water for 4, 5, 6 hours, our specific gravity of our urine is actually going to go up, right? Meaning it's going to become more concentrated because our body is going to say, oh, we're not getting water in, so I'm going to start conserving my fluid. Patients with diabetes insipidus, they don't have that antidiuretic hormone. So they're just going to keep peeing. They're going to keep releasing that fluid. And so that specific gravity is going to stay the same. Their urine is going to remain very dilute. You're probably going to see some other changes in these patients. blood pressure might drop. They're going to be begging you for water. Their body is needing that fluid. So therapeutic interventions, probably going to be supporting them with some IV fluids, hypotonic, usually just to get extra fluid in there. And because their serum is very concentrated, they're not, they just need fluid. They might have a hypophyseectomy if there's a tumor, and that's a removal of the pituitary gland. We might want to give them some vasopressin to help retain some of that fluid, or a synthetic form of vasopressin. So nursing diagnosis, deficient fluid volume for sure. And our expected outcome, we want to see that specific gravity, once we're treating them, become more in a normal range where it's not so diluted. We also want them to have a stable daily weight and stable, and those, like their skin turgor, non-tenting. Here's one of those little infographics about diabetes insipidus. Here's where the antidiuretic hormone, the pituitary thinks it needs some more antidiuretic hormone, but really it's turning it like where the kidney is just diluting everything. It's peeing it out. Here's some of the causes, nursing care, and what we do about it. So SIADH, or symptom of inappropriate antidiuretic hormone, that's where you have too much antidiuretic hormone. So that's a direct opposite of what we were just talking about with diabetes insipidus. So they are going to be retaining that fluid. Because they're retaining all that fluid, they're also retaining the potassium. Their serum osmolality in the blood, meaning that concentration of the blood, is going to be very low, right? Because it's diluted in their blood. The causes, it can be some of your nervous system disorders, could be related to cancer. There are some cancers that will release a substance that's similar to antidiuretic hormone or that mimics it, that causes people to retain those fluid. Sometimes different pulmonary diseases can cause it, or medications. So signs and symptoms. You're going to see weight gain for these people, right? They're retaining the fluid, but you usually don't see the edema that we would see with diseases like heart failure. There's going to be what's called dilutional hyponatremia, meaning that their sodium levels are going to read lower than 135, but they actually have a normal sodium level. Why is that? Okay, hopefully you thought or maybe read the book. Because, like, so let's say you or I, we have a normal sodium level right now, but if we retain a bunch of fluid, that sodium level is going to be diluted in our system. Now, do we have the amount of sodium that we need for body function, normal function? Absolutely, we do. But if you draw our blood work, it's going to look like we have a low sodium level because it's so diluted. So with these patients, you really have to be sure you're looking at their lab values using that critical judgment, because with this person, we don't need to replace their sodium, right? They already have enough. We need to get rid of the fluid. Their serum osmolality is going to be high. It's going to be very concentrated because they are retaining all that fluid. So the urine is very concentrated. They might have muscle cramps, weakness. This can eventually lead to brain swelling, seizures, even death. Some of the diagnostic tests, similar to the diabetes insipidus, where there's too little ADH, but we're going to check our urine and sodium, our urine and serum sodium osmolality, and then probably get some scans to see if we can find a cause. Therapeutic interventions, we're going to get rid of that cause. If it's a tumor, we're going to be removing that tumor. We're probably going to do a fluid restriction, right? Because since they're not urinating and diuresing, we don't want them to keep having more fluid in. They don't actually need more fluid. We're probably going to be giving them some medication to help release some of those fluids, some diuretics. Nursing diagnoses are going to be fluid volume excess. And our expected outcome is that, kind of similar to diabetes insipidus, we want their weight to be normal. We want to see what their I&O, have that be stable. And we want to see their serum sodium level within normal limits. You don't maybe have a partner with you at home, but think about it for just a minute. So go ahead and think about diabetes insipidus and SIADH and think what's similar and what's different. Oh, oh. Me too. So talked about SAH. Skip over the cue recognition. You can pause on these if you want to look at them. All right, so now let's talk about growth hormone imbalance. So you're either going to have too little growth hormone, which means you're going to be pretty short in stature, or you're going to have too much growth hormone, which is going to be gigantism, acromegaly could be result. So growth hormone deficiency, you don't have enough. If your growth hormone is deficient in childhood, it's going to mean that you're pretty short. When you're an adult, it doesn't actually affect your growth or your height or stature. It can be caused by pituitary tumor, it could be hereditary, psychosocial, maybe malnutrition. Psychosocial, that one's kind of an interesting one, right? How can your growth hormone be affected by psychosocial issues? I really like the example that we used talking about foster children. In and out of foster care for years, unstable home life. They got placed into a stable home. They were all very short in stature, very like in the 1st percentile for height and weight. After several months in this stable environment, they all start growing. Why is that? Well, the stress of living in an unstable home environment probably caused the release of like cortisol in their system that decrease that growth hormone production, and they just weren't growing as a result of that. Once those stressors were reduced, they're then able to grow more. So signs and symptoms, anything 5th percentile and lower might only grow up to 3 to 4 feet if it's not treated. They might have a very slow sexual maturation. And then other symptoms depend on what other hormones are involved. So signs and symptoms in adults, right? This is after somebody's already grown, they are adults, but they said they have suddenly like maybe a tumor that forms somewhere, and they're now having a deficiency of growth hormone. So, and remember the growth hormone in adults helps with bone maintenance, muscle maintenance, all of those types of things. So you're going to be fatigued, weak, you might have excess body fat, cholesterol may be up, decreased muscle mass and bone, sexual dysfunction. You're going to be at risk for a lot of other diseases. How are we going to diagnose it? Well, they're going to do some blood tests. They're going to check for your growth hormone level. They're also going to see how you respond to hypoglycemia. That's going to show them how your body's affected by this. They might do some scans looking for a tumor. And then we're going to be giving this full growth hormone. We don't have enough of it, so we're going to give it to them to help correct some of that. Or if there's a surgery that's causing the issue, we're going to be actually doing surgery to remove the issue. Nursing care, approaching with respect. I think this is more targeted to people who have growth hormone deficiency children at very short stature. This could be something that people would be sensitive about. I'm going to ask them what current problems or challenges they have. We want to say, okay, you're injecting yourself with growth hormone correctly. I want to make sure the patient's getting the correct education. So acromegaly is when you have too much growth hormone, especially in adults. So when you're in a growth hormone in adults, you've already grown. Bones aren't going to grow more in length they will grow wider. Those growth plates that we have for children are already kind of sealed, so we can't really grow and like taller necessarily, but they can grow wider. Somebody who has increased growth hormone while they're still growing will be excessively tall and have, excuse me. So they will be very large in stature. Um, their organs and connective tissue is also going to be with that growth hormone increase. And it can be from the pituitary, having overgrowth, maybe a tumor, and your hypothalamus having dysfunction. So signs and symptoms in adults, they're gonna be like, hey, my rings have always fit, and now they don't. And it's not because I'm swollen, my hands are bigger. You're gonna see people with kind of this big sloping forehead that keeps enlarging. Their jaw might increase in size. Because of that, the teeth might start being moving around a little bit and shifting. They can have a larger tongue as well. Might make them have a little bit of slurred speech, difficulty swallowing, sleep apnea. It can lead to a lot of other issues, arthritis, sexual dysfunction. Here's a picture where you can see somebody, their hands, where their hand first was, and then where their hand grew to. Quite a bit different. And then this picture below here of this man, you can see how he's got this like large chin and jaw. And here he's got this big sloping forehead. And that's because the bone tissue has continued to grow in its own way. So how are we going to diagnose it? Well, first, we're going to get a growth hormone, right? We also want to see how do they respond to glucose, same as the two little growth hormone. We're going to get some x-rays and scans kind of to see if we can find out why this is an issue. We're going to treat the cause. They might have to have their pituitary gland removed. And we're going to talk about that. That's a hypophosphatemia. If that's the case, they're going to have thyroid replacement, but not thyroid, several hormones to be replaced after that. Here's another one of those visual aids. People think Abraham Lincoln probably had growth hormone excess, and that's why he had that very distinctive look with the forehead, jaw. Talks about complications, the growing of your hands, feet. Anyway, just kind of a nice little visual. So let's go and talk about a hypophosphatemia. So that's where you remove the pituitary gland. It's pretty minimally invasive because you can see this picture. You can go right through the nose with a scope up into this pituitary, gland. Before they even have surgery, we want to make sure we're doing some good education. We want to see what is their neurologic status, really good neuro assessment before the surgery, right? Anytime we're going and messing inside somebody's brain, we want to know where you're at first so we can make sure we're checking after surgery as well. Really want to teach that after surgery, they're going to want to avoid putting pressure on that surgical site, right? So think about, they're going up in your brain, but through the nose. Things like sneezing, coughing, straining as they're going to the bathroom. Those are all going to put increased pressure on the surgical site. We want to let healing happen. So we're going to be decreasing those things. We're going to be teaching them deep breathing, exercises, and spirometry. Afterwards, we're going to be making sure we're doing really good assessments. We're going to check their urine for specific gravity because they're going to be at higher risk for diabetes insipidus, right? They're probably going to have a nasal packing, maybe a mustache dressing. And mustache dressing is where I had a little mask here to show you. I don't know where I went to. Well, essentially, mustache dressing is where you have a mask, but you just, instead of putting it over your face, you just kind of fold it up so it just kind of goes right under the nose. And you put some gauze underneath where that mask is so that anything that kind of, you don't want to really just pack the nose so it all backs up, right? You want to let it kind of be able to drain. And so it just drains onto the gauze, and the mask kind of keeps it keeps the gauze on there. That drainage should be kind of a serous. If you see only a clear fluid, we want to make sure it's not cerebral spinal fluid. We'll talk about that. So patient education, first of all, how do we keep that pressure down after surgery in the brain? So if they need to blow their nose, it's going to be very, very gently, if at all. We want to make sure we give them medicine to keep them from straining while they have stools. So some stool softener, stimulants, and then antitussives for coughing for any reason. We don't increase that pressure. We want to make sure that they know when to call issues. So now you can think about what is growth hormone deficiency, what excess. All right, cue recognition. I'm not going to go through all these. You can pause on the slides to see if you recognize the cues. All right, cue recognition. I do want to do this one. You're caring for a patient who got a hypophyseectomy, so with pituitary. There's a small amount of clear drainage coming from the nose. What do? You know. Well, if it's just a little bit of clear drainage, you're like, is this cerebral spinal fluid? Or is it stopped, right? You check with a glucose strip, just like you would check somebody's blood sugar, but you just run that test using the drainage from the nose. Why do we do that? Well, if it's not, will it have glucose in it? No. Does your cerebral spinal fluid have glucose? Yes. So if that comes back positive, like if it has, if you get a glucose reading, that means it's probably cerebral spinal fluid. And that's a problem because we do not want cerebral spinal fluid leaking from our nose when we have a surgery that way. All right, so let's talk about thyroid hormone imbalances. So hypothyroidism, right? Hypo is low. So you have a thyroid hormone deficiency, means your metabolic rate is going to be reduced. If it's a primary thyroid problem, you're just not producing enough thyroid hormone. If it's secondary problem, you're not getting enough of the thyroid stimulating hormone. Could be congenital, could be inflammatory, might be an iodine deficiency. Maybe somebody had a thyroidectomy, or it could be autoimmune. Hashimoto's disease is where it's autoimmune where your body attacks the thyroid gland. So signs and symptoms, think about that metabolic rate being slowed down. So these people are tired. Their heart rate is low. They're constipated, right? The digestive system is slow. They can't handle the cold. They not handling it at all. Hypoventilation, taking deep breaths. Their skin and hair is going to be really dry. They're going to have some weight gain. They might develop heart failure and high cholesterol. Complications, myxedema coma. That's where you have a combination of hypothermia, their vital signs, level of consciousness are just trending down. Eventually can lead to respiratory failure and death. So this could be a big issue. So diagnostic test. We're going to see their thyroid, T3 and 4 are both going to be low. Primary thyroid disease or primary hypothyroidism, TSH is going to be high, right? Because that pituitary is sending TSH. It's like, hey, make more thyroid, make more thyroid. It's sending the signal, but the problem is at the thyroid itself that's not working. If it's a secondary issue and the pituitary isn't sending enough TSH, the TSH levels are low. So what are we gonna do? Probably gonna give them some thyroid, right? If they've entered this myxedema, they're just circling down. This is a big issue. We want to monitor them, we want to get them warmed up, help them breathe, to support their blood pressure, whatever else it needs to do. It's a crisis. They need to be in the hospital. Here's a nice little picture of this hypothyroidism. He is cold, he's got his body lotion because he's dry. Uh, he just lethargic. He just doesn't feel good. Here's another thing I like to just touch base about when we're talking about thyroid issues. Synthroid, you can see there's this little ladder where over here, this guy on the left side, his first day, he does not feel good, right? It's his first dose. We get up to the seventh day, seventh dose, he's starting to feel okay, right? Slowly getting back to this metabolic rate. 14th day, he's feeling pretty good, right? This function's pretty much back to normal. But then the 15th day, he misses a dose. He still feels pretty good. Why is that? Let's think about it. Then he goes down to the seventh day, he's starting to slow down a little bit. And then by 14th day of missing a dose, he is not good at all. Remember, the thyroid is one of the glands that actually stores thyroid hormone. So here, he's storing up extra thyroid. That's why the first day he misses a dose, he still feels great. And the seventh day, after a whole week, he still isn't terrible. He doesn't feel great, but he still has that stored thyroid there. So with these patients, it's really important to tell them you need to be consistent in taking these thyroid medications. Because if you miss it, you're probably still going to feel good. And then patients might think, oh, maybe I don't really need this. But eventually they're going to feel pretty poorly. And then it takes a while for them to then feel good again. So now let's talk about hyperthyroidism. So this is opposite, it's the increased metabolic rate. So the primary, too much thyroid, secondary, something's going on with the pituitary gland and they're sending up too much of the thyroid stimulating. So it could be autoimmune disease, that's Graves' disease, and that's where it's causing too much thyroid release. You might have a goiter, you might have thyroiditis, inflammation, you might have a pituitary tumor, right? That would be a secondary issue. You might even have too much other medicine. So signs and symptoms instead of the hypothyroidism, where I kind of like it's the hypothyroidism is too low, everything is too low. Hyperthyroidism, everything is like sped up. So hyperbolic metabolic state, right? These guys are just burning calories and burning things without even trying. They're going to be hot, eat all the time. They're probably still losing weight. Your GI system is sped up and they're having frequent stools. They're like nervous, tremoring. They might have heart palpitations. They might, in Graves' disease too, they might have exophthalmosis. Yes, I ever heard. It's where their eyes kind of bug out. Oh yeah, I got a picture here. You've probably all seen somebody who kind of looks like that. Might have some issue with their thyroid. Signs and symptoms in the elderly, sometimes their heart, right? The palpitations, fatigue. So you get into what's called a thyroid storm or a thyroid crisis, and that's where it is or not in the good state. Our heart rate is too high, blood pressure is too high, you got a fever, dehydrated. Eventually, these people could enter a coma and death. So it is something we need to treat urgently. Diagnostic tests, pretty similar to hypothyroidism. We're going to check their thyroid levels. What's your thyroid stimulating levels? Maybe some scans to see what's causing it. Our interventions, we're going to give some things to slow down what's happening. We're going to try to slow down the heart rate, slow down the blood pressure. We're also going to take out that thyroid or do something to help prevent it from producing so much thyroid. If they're in that crisis, we're also going to be whatever else they need to do. Here's a little picture of our patient with hyperthyroidism. Look at him, he's got this bulging. He's just so hot. He's got tremors. He's lost all this weight. He's not feeling good. So sometimes for patients who have hyperactive thyroid, you might go ahead and give them a radioactive iodine. thyroid. That'd be very impressed.